Hello, my name is Casey Keys. I'm a second-year comm student with a background as a paramedic in Minneapolis. After the death of George Floyd this summer, I was inspired to fly out to the city and volunteer as a street medic alongside the protests. During my time as a street medic, I saw that a lot of my other protesters had no formal medical education. Upon returning to campus in the fall, I was inspired to reach out to CECE and other allied health professionals to try to put together an event that would allow them and inspire them to use their experience to contribute to times of civil unrest. As a comm student too, I feel like I don't get a chance to interact with the other allied health professions, and this gave me, despite COVID, a chance to interact and collaboratively work together on a project with a number of allied health professionals.
Hi, I'm Bethany. I'm a second-year occupational therapy student with EMT experience in New York and Pennsylvania. Casey did a great job of gathering a whole group of allied health professionals to work with, which was really empowering as somebody coming from an EMT background into this group with lots of different allied professionals to work with that same shared background. As an occupational therapy student on this team, I really focused on preparing to be a medic and what that would look like, as well as the mental health component of providing aid within this context. The other piece is that during the entirety of this project, I was in Portland, Oregon, completing my second level 2 fieldwork opportunity, which impacted when we could and could not meet.
I'm Chris Eidson. I'm a first-year doctor of physical therapy student. I was recruited by Casey and CECE to bring my unique perspective as both an EMT and a combat veteran to this event. Along with that, as a physical therapy student, I really wanted to focus on bringing the perspective of trauma-informed care as it relates to protest medicine.
I am Wyatt Blackstone. I'm an undergraduate here at UNE, and I was recruited by Casey and CECE based off of my experience being an EMT for 3 years doing 911 transport, as well as a fire line EMT, providing my experiences with environmental hazards as well as triage to this event. I was also able to bring in a lot of the undergraduate community as well as the undergraduate EMS community to this graduate level event. And I'm very happy how this event went, providing education resources to the community inside and outside of the classroom during this event and well after.
Hello, my name is Casey Keys.
Alrighty, and at this time, if anyone has any questions for the team that presented, please feel free to ask. Or if the team would like to elaborate at all, we do have until 12:18 to discuss your poster presentation.
I'm going to unmute rather than be in the chat, and I'd love to hear more about the trauma-informed perspective that you brought into this presentation, because there's no doubt, first of all, amazing presentation. Just want to say that on all levels. But I'm curious about how you infuse trauma-informed practice and trauma-informed skills into the work that you did.
I mean, Shelly, this is something we talked about after the event, but that's a facet that we could have done a much better. I mean, better, but we could have explored that deeper. I think a lot of the presentation focused on the nuts and bolts, and the poster was kind of the collaboration between us interprofessionally. But that is something that's extremely relevant for the post-event de-escalation, debrief, how to hopefully incorporate your experience into a meaningful narrative moving forward. So I think just reflection on that, taking time for self-care in between, because as my time in Minneapolis this last summer taught me, engaging in protests day after day is exhausting, physically, mentally, emotionally.
And that, I mean, to our credit a little bit, Casey, that was something that we did talk about in this, when we were initially planning and when we were discussing what each of the interprofessional roles would have. I also think, do you have top 3 things you'd want someone to know about protest medicine?
Yeah, I would say first thing, anyone can get out there and do it. Get a tourniquet and some Narcan and a bag of Band-Aids and some sunscreen, and you're good to go. I mean, that's grossly reductionist, obviously, but I think that's the top thing is feel empowered to engage however you want to engage. And the second thing, right off that, is there is no cookie cutter formula for how you want to do that. I think the inspiration for this came from seeing all the protests that were happening and knowing that I had experience feeling powerless and frustrated and wanting to engage with the protests in a meaningful capacity. And that looks different for everyone who chooses to engage with them. But I think it's just because you can be aware of like that full spectrum of how to do it. Then I think that's what this was trying to encourage you, is like, these are the information we presented was a variety of avenues you could explore, things you could engage or like dig deeper in. And that being said, like, take or leave whatever works for you. And I don't know how the third is, I don't know. I can't think of anything snappy off the top of my head.
I think the third for me would be, don't become a victim yourself. Like, there is some level of like like yes, you can engage what you want, but like know your scope of practice and know the area, like do your homework beforehand so that you don't put yourself in a position of like danger.
Yeah, and before, like, I know we're running low on time, but the last question, this is different than a typical EMS role, because typical EMS role, you have like a much more like, you have protocols, you have ambulances, you have operations and comms. Like, this is a much more like ad hoc, you have to like kind of operate by the seat of your pants. There's no formal communication. A lot of times like phones and typical things like that don't work, just due to the number of people there. So it's much more an exercise in adaptability than it is, following standards of protocol, as like the difference between like protest medicine and like formal EMS work.
All right, thank you so much. And just a reminder, we do have time at the end for additional discussion if you have additional questions.
Pandemic Plan Wellness on Wheels addresses the racial and ethnic discrepancy in accessing medical care during the COVID pandemic, and provides some solutions. So in Maryland, it was found that Black Marylanders had suicide rates double, and white Marylanders, they decreased by nearly half. And loss of employment unequally hit Hispanic and Black communities. COVID deaths and COVID vaccinations do not align by zip code. To care requires transportation, convenience of location, having childcare. Many individuals delayed seeking care, including urgent care, for fear of exposure to the virus in hospitals and medical offices. Structural barriers to accessing medical care already existed in Black communities who were more likely to be uninsured, not have a primary care doctor, and live in an underserved area. A report by New York City's comptroller showed that 75% of frontline workers in the city are people of color. Occupational hazards that are compounded by the fact that only 55% of essential workers in the food service industry have access to paid sick leave. Disproportionate burden of chronic medical conditions is compounded by lower access to medical health care. Among some racial and ethnic minority groups, uninsured rates among non-elderly Americans are significantly higher for Native Americans, Hispanic, and African Americans compared with whites. They tend to live in areas where medical care is of poor quality or is underserved. Therefore, racial and ethnic minorities may receive lower quality of care for COVID-19. Also found that higher median income household counties, so Cumberland County with 75,000, had the highest vaccinations, whereas Washington County had the lowest. Our solution to this is wellness on wheels. So getting fleets of medical vans and buses to access directly and provide medical care to underserved rural and urban communities as needed. We would deliver PPE and care packages. We would provide testings. We would address the disparity of access and transportation to health. We would also provide pantry bundle delivery services, ready-made meal bags for the homeless, and again, transportation of community volunteers, childcare, mental health staff, and social services. Utilizing local volunteers. This will give us kind of informed care and a representative that was trusted by the local community. And our mental health focus would allow for us to apply the same model, establishing a sense of unity and togetherness. And the incredible amount of debt occurred by the United States shows that, this is something worth raising.
All right, and at this time, if the team would like to expand at all, or if there are any questions, please feel free to ask.
Well, I'm going to just do it again, and because that was a phenomenal presentation, very powerful, very relevant, and I'm curious about those of you who put this together, this presentation together, this idea of mobility and going into communities rather than communities coming to established centers. I'm really curious where that idea came from. And also the interplay of rurality here, which, is really important. I'm sorry, that was my dog snoring. I apologize. So I'd love to hear from the presenters.
So how we got started was basically we listed everything we thought went wrong with the coronavirus pandemic response. And then we tried our best to kind of find common determinants. And a lot of that was lack of access to care because either, again, people just did not feel safe to reach out to, healthcare access points. We wanted to decrease the amount of contact they had. So, obtaining groceries, obtaining PPE, competing with each other for this PPE. So we really set like individuals against each other. And, it was very isolating for people to try to stay in and not get, anything that they needed. So that's where it came from. I'd welcome any of my teammates to add to that.
I have a question. I'm wondering if you had to navigate or negotiate roles and responsibilities as you thought through that.
Do you mean specifically between like state and federal, or the medical staff itself?
The staff, the actualizing your idea.
Yeah. So I think that's where kind of the division between like medical fleets and the social support fleets would come in. So medical fleets, that's kind of already an established responsibility hierarchy kind of thing. So you would have kind of medical professionals, nurses, and then for the social aspects, we would want social workers, psychiatric care where needed, and childcare. So that's where it would kind of need a little more work.
It also looks like there's a question in the chat from Casey saying, did you draw any inspiration off of any previous projects or initiatives? If so, what were the unexpected successes and pitfalls?
So we actually did not. It was really funny because after our initial meeting, I saw after we had already come up with this plan, on my Instagram, I saw that New York City did like vaccine buses. And I was like, well, it must be on the right track. So no, I did not see any other ideas similar to that. And it would have been smart to incorporate any successes or failures.
One thing we liked was we looked online about other resources we could get with vans, and we saw the van concerts through the vans, which we thought was really great for adding the social component, because it's kind of like a moving stage and it's really good for social distancing. You can kind of make, you could have exercise classes, concerts, talent show type things. So some things that people can look forward to in the community. It can be kind of an event that people can look forward to and bring the community together, because we really want to incorporate this kind of the community building aspect as well, not just kind of treating the medical aspect, but really helping the mental and emotional health of the communities as well.
All right, thank you so much. And again, we will have additional time at the end for any other questions or thoughts. Thank you, Wellness on Wheels. And if you would like to switch any between breakout rooms, now would be the time to do so. And here is just another little IPE reflection that we have, and we will move on to the next team.
Hello, thank you for taking the time to read our interprofessional approach to a pandemic plan. In this voiceover, I'll be quickly reviewing the topics we present in this poster. In pre-pandemic times, we put a focus into PPE cycling to ensure several months of supply, financial buffering for healthcare firms and state budgets, identifying alternate roles that staff can fill and training them for rapid redeployment, as well as contracting doctors outside of a hospital's own system to be used as reserves. With regards to disease surveillance, Maine immigrants do not have access to Maine care, which may cause a blind spot through their inability to receive care. Support for Bill LD 718 can resolve this issue. Also, we believe that international cooperation should be pushed for as a change in culture that sees it as immune to diplomatic tensions. With regard to containment and mitigation, the primary concern will be initial containment and identification of the pathogen. Structural healthcare system issues in the United States prevented an immediate and efficient response. Prevention can be supported with overall cleanliness of public places and businesses, reduction in number of live markets, and decreased antibiotic use in farm animals to reduce the spread of infection. Overall, an increase in communication between hospitals and governments will help with current and future infections. We must consider form of government and cultural orientation when assessing successful pandemic responses, because this impacts how much control countries are able to have over their citizens and how many individual liberties people are willing to give up. Vietnam was an example of an extremely successful Eastern country. They were successful through implementing travel restrictions, closing their border to China, implementing strategic health checks, contact tracing, and a 2-week stay in quarantine centers, in addition to closing schools and doing this all very early on in the pandemic. New Zealand was an example of an extremely successful Western country. They were able to do this through excellent communication between government and people, and by striving to find, test, isolate, and care for every case of COVID-19 in their country. With regard to vaccine equity, we focus on fair distribution and making sure that everyone has an opportunity to receive the vaccine. Governments can help to ensure ample supply through tax cuts or direct funding for biotech companies. We also look into different ways of engaging community leaders to help get vaccine to underserved and minority communities. Lastly, we look into open communication and how trust in the government and scientific community can lead to greater rates of vaccination. Each discipline must work together to be successful in any plan. Public health professionals are required for multiple parts, from disease surveillance to policy creation. Most importantly, though, they are a good point of communication for the public. Community leaders can also be utilized as liaisons to providers. Ultimately, communication is key. If you have any questions or would like more information about our plan, please email me at bpastory@une.edu. Thank you.
All right, and if there are any additional questions or comments about the presentation, now is the time.
I have a question. What part of your plan did you find most challenging to try to tackle? And then also, two-part question. How did being interprofessional help you guys tackle that?
For me personally, I think seeing the amount of miscommunication that really went into like COVID-19 with our government, and how we can try and change that for the better, really, like, it was difficult for me to like grasp, because it seems very simple to just present information that is correct, but then it can be twisted and not actually followed. So trying to figure out how to reduce that is very difficult in my opinion. And then also looking, so I was in the containment mitigation part, and looking at like things like deforestation and animal markets and stuff, and the antibiotic usage in the United States, and how much we need to reduce our like handling of animals when we're sending them out to be used for consumption and whatnot, is a big product of, spreading of infection. So trying to figure out what to do with that also was also difficult, I thought, too, because that's something that I personally can't do, but it's something that we should try and like look into and fix. So if my teammates want to elaborate as well.
Yeah, I think also being interprofessional really helped us to have a good perspective. We had Ben from pharmacy, which is kind of fun to hear his thoughts on vaccine distribution. And then Chandler's PT, and the rest of us are from the comm program. I also saw Dr. Timi's question about conflict of thought or strategy between leadership. And we elaborated about this a little bit more in our full presentation, but I looked into successful pandemic responses. And one reason like New Zealand in particular was so successful was that they're able to come up with this really centralized plan and provide this like frontal leadership and execute this. So I think that that's really important for like successful pandemic response, is coming up with a centralized plan and being able to execute that as like one group.
Yeah, kind of to backpack off of what Savannah had said, I looked into some research that showed that kind of trust in one central government led to higher vaccination rates. So it really just depends on like the culture and how much people trust their government or like the leaders.
I was thinking about the relationship between the Wellness on Wheels and this presentation in terms of thinking about race and ethnicity and more vulnerable populations and the engaging various leadership in promotion. And I'm just curious whether that was factored in as you pulled this presentation together. And I see we only have 1 minute for that very complicated answer, but I just saw a nice relationship between those two presentations.
We
Yeah,
primarily looked into how we could reach out to more underserved communities through community health workers. And we did this through looking at the roles and responsibilities that we generally see with community health workers. And we've seen a lot of people step up to the plate in international settings. And I think that if we were to utilize that as that role and like have more of a program to train more people to be community health workers, we could reinstate some trust in healthcare and medicine and science in general that may have gone by the wayside in the past due to past events such as the Tuskegee trial.
Thank you.
All right, thank you, team 2. And at this time, if you would like to switch between breakout rooms, please do so. And a reminder that we do have additional time for questions at the end.
Hi, everyone. My name is Sean Callaghy. I'm a first-year medical student with the College of Osteopathic Medicine. The title of our project is Hindsight is 2020, Plan, Perform, Evaluate. So this is a quote from Dr. Schwab. Behind every single one of these numbers of cases is a person. Every one of these cases represents someone's friend, spouse, mother, child, neighbor. So we continue to ask that we treat them with the humanity they deserve. And here's a summary of our project. So basically, we developed a multidisciplinary plan that kind of analyzes best practices and kind of failed performance indicators across 4 different areas: education, public health, infrastructure, and mental health, which kind of ties all these things together. And so we use research to show what measures should have been taken to prevent the fallout if such a significant catastrophe might occur again.
Hi, my name is Will Rinaldi. I'm a first-year student, College of Osteopathic Medicine here at UNE. Throughout this presentation, we discussed 3 potential plans that are geared towards education that can be utilized in case we ever need to encounter another pandemic, or in case we ever encounter another pandemic or natural disaster like the one we just experienced. The hybrid model is the best way to assure that we keep schools open for students that need access to vital biological resources, a safe and productive learning environment, and the necessary tools to ensure for a maximal learning experience. Specifically for urban schools, one future direction may be to develop and maintain partnerships with community organizations to prevent food insecurities during the school closures due to pandemics or natural disasters. And then the cohort model, which is a part online, part in-person plan that will promote integrative and efficient learning for all students, regardless of their social backgrounds.
My name is Katie Santinello, and I'm a first year in the College of Osteopathic Medicine. I have my Master's of Public Health and Epidemiology. So I came up with 3 public health recommendations for our pandemic playbook. The first of which is grassroots organizations and investment in them is necessary in order to garner community engagement. Decentralization of recommendations is the key in order to effectively communicate with many diverse communities. Secondly, accurate and timely information sharing that impacts the health of the population must be mandated by global entities. And finally, best practices and globally shared protocol must be available on an easily accessible platform in order to decrease morbidity and mortality regarding research, treatment, and/or immunization.
Hi, everyone. My name is Michaela. I'm a 3rd-year Doctor of Pharmacy candidate. My role here is to discuss infrastructure, which includes the government and our economy. My recommendation is as follows. In order to maintain public health while preserving the economy, our government must provide aligned early public health messaging from public health officials and government officials, create a strong, sufficient unemployment plan with incentives for businesses to stay open, offer support for businesses converting to telework, enforce the requirement of adequate safety measures for employees who must physically attend work, and finally, to offer childcare support for parents who are working to keep employees in their roles.
Hi, everyone. My name is Belle Bogle, and I'm a first year in the Masters of Social Work program. My pronouns are she, her, hers. These are the recommendations for mental health. Studies show that mental illness may soon be the most common pre-existing condition. We must continue to train the next generation of healthcare providers in an interprofessional manner to provide the best client-centered care. Our next recommendation as a team is to integrate mental health into the preparedness and response plans for public health emergencies from the onset. And lastly, we recommend that we should gather more data and conduct research on at-risk populations across all disciplines. We recommend census level data, insurance level data, social service provision data, and the specific pain points that we looked at are access, usage, and stigma. Thank you. At this time, we'd like to open the floor for any questions.
I really liked the integration of mental health into this concept because I think so many people think about process exclusively when it comes to planning for this. And I see mental health on both sides, both providers and the patient client level. I'm wondering, like, what was the scope of mental health that you envision, or what areas do you think you would prioritize as part of that?
Hi, Dr. G. Thank you for such a thoughtful question. It's really good to see you. So we talked about mental health as underpinning all 4 of these silos, and I have to confess, we only had 30 minutes, right, for our original pandemic plan competition, and we only had 3 minutes, and I can't confess to you how many times we took the star in video. So the outtakes are really funny if anyone ever needs a chuckle late at night. But mental health on the way that we train the future of healthcare providers, from studying for boards, from the way that we're all in exam periods, from how we'll be in residency and clinical rotation, that's super important. But how we come off of the role, and I even remember the first time we all met, it was 6 days after the spa shootings in Atlanta, and even the way I introduced myself to my team, I gave my pronouns. I identified myself as AAPI, which is Asian American Pacific Islander. And the reason that I said what I said is because if we are in a rotation and we are not sharing part of ourselves as the identity wheel, how are we going to show up in a community pharmacy, in the ED, in a social service agency for our clients? And so to answer your question, and I'll popcorn it to my team, we are whole people treating whole people. And so as a higher ed institution, how are we bringing into the classroom real examples like this IPE to remind ourselves and our students that when we go out into the real world, that's what we're doing?
Yeah, and I'll add, I'm Katie from College of Osteopathic Medicine. Thank you, Dr. Dornblaser, for your question. Again, it very much aligns with the osteopathic mentality, right? Treatment of the mind, body, and spirit, just exactly what Belle said, whole people treating whole people. So I just wanted to add that it's very osteopathically minded, and just to make sure you're aware of who you are and what you come to the table with, so that your patients can feel confident in telling you what they need to tell you.
Hi, everybody. I have a quick question. This is Jen. I'm from COM as well. And this is very impressive. I think it's really comprehensive, although basic. I'm not familiar with the context for you creating this. So I'm curious about that and how you might be able to share it as a model that folks could consider in the future.
So we got involved with this project through the pandemic plan competition that was run by the Infectious Disease Association, which is an interprofessional organization on campus. However, it's run generally by student pharmacists, including Sandra, who's the president. So we got involved and we all came together as a team through that competition. But then we sort of recognized that there wasn't a great amount of guidance for what to do during our current pandemic. And our idea to make this playbook sort of came from all of us coming from different backgrounds, making different recommendations and wanting to make it really concise and clear for future health professionals to be able to read it and take it, and take away that initial work from getting started with the future pandemic.
Yeah, kind of going off what Michaela said too, I think when we first started this, there were so many different aspects we could have took with this presentation. We had to cut out a couple categories such as, more politics and economics. We actually had to combine government and infrastructure. So I think, it could have been taken and more focused and more towards bunch of different paths, but I think narrowing it down to those 4 that we kind of addressed during the presentation was a challenge in itself, and one that I think that we kind of executed very well. But yeah, it was great, and it was really nice to see how the interprofessional aspect of this whole project really highlighted each of our respective disciplines, being pharmacy, social work, and osteopathic medicine.
Thank you. That was very helpful.
Alrighty, at this time, I will share my screen one final time. Here is our last IPE reflection from an alumni, and it says, the effective communication with other disciplines allows for better decision-making for all us as professionals for the patient's care. And for the rest of the time we have together, we can have an open discussion about all of the presentations seen today. As a reminder, we have the protest medicine presentation and all 3 pandemic plan competition presentations.
So I'd like to follow up with Dr. Dornblaser. She stole my thunder there with the question about mental health, but this is a sort of a selfish question. I've been talking a lot with primary care providers and other health providers out in the field about the insufficiencies of integrating behavioral health and primary care, that we don't quite seem to have it down yet. And so one of the things we've been thinking a lot about is, and I'm asking really for your advice, is how do we do a better job of integrating behavioral health concept, mental health concepts into all of our health professions? That's number one. And the second part of that is, how do we deliver it? Should it be discipline specific? Should it be interprofessionally, or should it be both? Should we be looking at ways to make it seamless within the curriculum and not an add-on? So that's a big question, but I think every single one of the presentations touched on the need to integrate this knowledge.
Shelley, what a wonderful question. And I'll try to start with one example, and then I'll popcorn it. I want to be cognizant. Something that I read about just this morning that the team is that CVS is doing a pilot study, and they are hiring LCSWs, so licensed clinical social workers, to work in the clinic. And what is interesting is they are partnering with pharmacists. And I sent it to Dr. D because I thought this would be something that I'm always thinking about. So I read something, and now what can I do with it, right? And so I work for the university, and I'm a student at the university. And we had this incredible opportunity with IPE here that, frankly, I know a lot of folks don't take enough of an opportunity. We're already doing 1,000 things, especially in a pandemic. And so what the article touches upon is that maybe you are Susie Smith and you go to CVS to buy milk, and you're also picking up your prescription, but you see some literature, or you're talking to your pharmacist and you say, it's been a really rough couple of weeks, couple of months, and they hear something because they interact with you and they say, did you know that we have an LCSW here? It's really accessible, and that way you don't have to go find a mental health provider, or you don't feel comfortable talking to your PCP about that because maybe there's cultural stigma or cost or whatnot. And so you start seeing the LCSW at CVS. Maybe it's just one visit, but that takes out some access issues. And so this is a pilot that's only in 3 or 4 cities, but so that's a new way to integrate into the community. That's another delivery model, but how does that affect us here at UNE? Maybe that's something that the School of Social Work and the School of Pharmacy can develop a sim lab model so that, Michaela, my teammate, and Belle can partner in the future with. And then selfishly, our pandemic team, all 5 of us have already committed to potentially hitting up CECE for some grant money and taking the legs of our pandemic challenge and thinking about publishing this in a journal. We've already talked to Dr. Tom McLaughlin about a mixed study research of just taking one silo and doing a study on where this can go. So thank you to CECE for putting together an amazing team, and to Sandra for executing on ways to encourage people to work across their silos. We're not an echo chamber.
And I wonder if you could partner with the School of Dental Medicine, because they already have like all the community members coming in yeah, that's going to be a cool project.
I love that, Bethany. And if you could DM me your email, I would love to talk offline about that.
I'm not from this, I'm from OT and I'm graduating, but I'm sure there's
That is a great suggestion.
that would love to work with you on this.
So I'm thinking Dr. D and I need to have a chat about how to create a rotation, not just a simulation, but a clinical rotation at CBS.
I will forward you the email I sent her this morning.
Yeah, I read it though, and I was like, "Ooh, this is so cool."
Yeah, we can make this happen. Yeah, we can make it happen, and we have mini grant money. Just send us a proposal, and it's yours.
I think another thing to add, and I think Belle did an awesome job giving a phenomenal example of that, but I think our students are a generation that's mandating and advocating for our education on these topics in a way that's never been done before. So I think, you know, in College of Osteopathic Medicine, we're suggesting topics for grand rounds, and we're bringing up these conversations in our clinical skills learning. Like, how do we ask someone about their mental health? You know, how do we bring it up in the 15-minute visit? And then if it's not something that we think we can handle, who do we refer to and how do we do that? So I think us as a generation, more so than ever, I think is very cognizant of the mental health roles and the stigma that it has held previously. And we're trying to work very hard as the future generation of healthcare professionals to sort of figure it out first and foremost.
I also would like to just briefly talk about an experience that I had on fieldwork where I was in an acute care hospital, pediatric hospital, and we had no behavioral health like member on inpatient staff. It was just outpatient. So we had this patient who was there for like 6 weeks, and after like 2 weeks for like complex regional pain syndrome, and after 2 weeks of like OT and PT pushing and being like, yes, this person needs to be up and going to the bathroom, but they're in pain and there's a psych component and we need psych. We like finally pulled from the outpatient team and was like, look, someone's gonna have to come upstairs and help us. But like, they struggled a lot with like, as a hospital, how do we change our policies and procedures, and like the funding to get inpatient psych isn't there. So then it was all a mess, and it's going to continue to be a mess, but at least the conversations are happening.
Well, unfortunately, we've got to go. This is so sad, but meet you in the big room.